strangely freed up by what I was struck by was the extremely clear sense of common purpose when this virus started to take root. And I often talk about purpose when I talk to colleagues in the front line. I think it's a very precious and important aspect of our lives working in the health service, is that we kind of know what our purpose is. I have colleagues who work in other fields, and I sometimes wonder what their purpose is, if I'm being completely honest. But I know what mine is, and I think that purpose became very, very clear during the pandemic. And it led, I think, to what I could see from Paul Reed down around our organisation, a deference to expertise. If somebody knew what they were talking about and knew their area, everybody else listened to them. So there were people around the leadership team table who I'd never met before. I didn't know what their job was. And there they were calling the shots. They were telling us what the situation was. We all listened because they knew what they were talking about. They were the experts in their field. And that for me encapsulates what we need to hang on to in our healthcare system generally is people who know their own area, let them decide what should happen in their area. That's everybody in the health service. Everybody knows their own area of practice or of provision, and we should be deferential to their expertise on all occasions. And I saw that during this first phase of this pandemic. And very much a flattened hierarchy as well. As I say, if a frontline clinician or practitioner had an idea and it didn't matter where they stood in the organisation, I'd like to think that they were listened to. So a form of collective leadership that we've been pushing for in our strategic approach to quality improvement. And we've obviously involved the public a lot and patients. And I could see in a real acceleration potentially of sláinte care and a shift to the left to primary care, community services, because hospitals became a much more dangerous type of environment with a lot of people with COVID. So we have really had to ramp up primary care and community-based services. And while it was a necessity, it was benign unintended consequence, if you like, but one that we, accelerated some things we should have been doing for quite some time. And obviously the use of innovation as well, and we can come back to that. But there were a number of challenges, obviously. Non-COVID work was severely challenged, and much of it was paralysed by the redeployment of staff and by the inability of bringing people into potentially high-risk environments. However, it's really important now during this kind of second phase that we avoid this second challenge, which I think is really burnout. Maybe burnout's a strong word to use, but I think everyone knows what I'm talking about, because we all probably feel a bit of it, and I certainly do, and have done variably at times, where you really feel like you're kind of spent. You've put your shift in, and now it's kind of ramping up a little bit, at least at the moment. Certainly in terms of hospital care, not yet, but certainly expanding the demands in hospital care, and that will impact on the community as well. And we're maybe a little bit less resilient in this second phase. We need to look out for each other and look out for burnout and really be concerned about that. And the last kind of challenge for me is that we need to protect the frail and the elderly from whatever coming down the line, because they took a very hard hit in the first wave of this pandemic. John, I'm not sure how you feel about some of our learnings there as well.
Just before John comes in there, sorry, my sound has come back again. Thank the Lord. So just want to say to people, we want to get the chat box going. So if you're typing in the chat box, please pick the option for everyone so that everyone can see in the chat. So we'd be really interested to hear from you about how you've been affected by COVID in your workplace and your key learning. So get the chat box going, please. Sorry, John. Thanks.
No, thanks, Roisin, and I would concur there with Philip. I think I think certainly early on that the power of purpose, I think, was very, very clear, and I suppose people were seeing images from Europe, from Italy and Spain, and the really traumatizing events that were happening there, and I think that really galvanized people, and I think there was a sense of not being, in command and control of getting out of the way. And I think the lesson, I suppose, there to me is really the power of purpose. Now, that purpose has become a little bit more complex now. It's not just about staving off the surge that was coming early on, and that we may have to deal with to some extent again. But it's how do we redesign the health service in a speedy fashion to be able to meet the current demands. How do we do it in a way that we can meet all the non-COVID needs? How do we keep the service going as best as possible? So the need for purpose hasn't changed. It's just the sense of making that message clear, and I think that message is now, how do we all work together to deal with the current situation, and that we can't have the same stopping of vital services. I think across the board. I think one of the things that I've certainly noticed and been inspired by is the impact of, I think, younger staff, and young doctors, young nurses, and people who've really risen to the occasion there. And again, I think really inspired by that sense of purpose, and then empowered and that, to get on with the sense of work. And I've heard people, been interviewed on the radio or on podcasts, and really, they're kind of feeling that they've kind of, they've met their sense of purpose, that is what they signed up for, and they've, to some extent enjoyed, being really part of functioning teams. And how do we try and capture that and keep it there? And I think it is about devolving that leadership out there. COVID is that great revealer, I think, of things. And I think in particular, like you were alluding to, Philip, community services and the need, if you were ever looking for something to support the ideas of sláinte care, I think COVID has been it. We need to move so much more care out to the community. We need to make our services much less hospital dependent, and I think this is one of those great revelations, I think, that will help us, I think, in the years ahead.
Thanks a million, John. There's lots of really good comments coming in here into the chat box, and maybe we could just have some conversation in relation to those. So, for example, Michelle Tate has asked, she's just done a thesis prior to COVID on leadership styles and implementing QI and change. And a key finding was the importance of clarity of role and purpose. And we all have talked about that numerous times in other webinars through QITalktime as well. So she's asking, do you think we did this well in COVID? So do you think that we had clarity of role and purpose in terms of leadership and implementing change?
That's a very good question. And Michelle would be quite well positioned to answer it herself, I'd say, but because she saw an awful lot of what went down, if you like. I think we had a clarity of purpose. We weren't clear about what we were going to do because we never confronted this before. We didn't know how the virus behaved. We didn't know that it could spread asymptomatically at the start. We didn't know. We were only working out its incubation period as we were going along. We were working out its infectivity period as we were going along. As you can see, that's potentially changing now this week. So we continue to learn about this. So yeah, while we had a clarity of purpose, which was to protect our population by maintaining an effective health service to care for them with whatever this virus threw at them. Maybe one of the things that was occasionally a casualty was clarity of role. Because I was at meetings where, there'd be about 7 different mini crises hitting the table at the same time. You deal with them, you say, well, why doesn't so-and-so do that? And this other person will do that. People were pretty much told we didn't have time to have a lot of discussions about things. And that clearly is suboptimal. But the pressure on decision making was absolutely massive. I mean, it was. I've never experienced anything like it in any walk of my life, and I think that did lead to some duplications of roles at times. Sometimes 2 people were asked to do the same thing. There were groups set up that overlapped. So yeah, I think we do better. We could do better on that, and we should do better on that now in this phase of hopefully slightly more considered response to whatever challenges this current phase hit us with. So I think clarity of role was at times lost. Clarity of purpose, I think, was always there, though, I think.
Yeah, another interesting comment here from Julie Bellew around the use of, she's part of the National Virtual Health Team, which is rolling out the Attend Anywhere video-enabled care. And she's saying a lot of what they've seen was very in line with your comments. Great sense of common purpose, massive sense of service, respect for all expertise, total focus on the task in hand, and acknowledgement that we were all doing our best, looking out for each other, and compassion was also key for us. So I think Julie has hit everything there in terms of what you were saying, Philip, as well. So just some other comments. Padraig Doherty.
She added coaching.
Sorry?
Sorry, just thinking just about what you said. She added the term compassion, which I maybe mentioned earlier on, but that's something that can definitely be lost in a crisis. Somebody's going through something difficult. Do we have time really to be dealing with this? Putting an arm around somebody virtually, obviously, rather than physically. And, that's something we need to be careful of. And I did a webinar with Michael West on compassionate leadership last week, and there was real emphasis on that, and that's what'll protect us from burnout and kind of loss of morale, I think. So I think that's very important. And just to say, the virtual health team have done a great job, and we're going to be partnering with them through a colleague who's working with me, David Vaughan, who's been in touch with the Attend Anywhere group who presented to us, and we hope to kind of support a kind of fairly systematic and considered approach to the use of virtual consultation and virtual interaction with our service users.
Yeah, great. We have two questions here. One from Padraig Doherty, and he's asking, what are the thoughts on how we should support services and clinicians to transition to new forms of delivering care and not revert to the status quo pre-COVID?
Do you want to start on that one, John, and I'll come in?
Yeah, I mean that is a great question, and I think there's so much in that, and I often think, if by some act of magic the pandemic, disappeared tomorrow, how many practices would we simply go back to doing, And again, I think it's back to thinking of COVID as that idea of the revealer. It's shown us so many things, and let's say just talking about telehealth there. Telehealth is a really, really good way of engaging with patients, and it if it's used correctly, it's something that patients really appreciate. Not every interaction can or should be obviously delivered by telehealth, but for many people, you are, and I speak, let's say, in my own clinical scenario here, where people might be coming from halfway around the country for a 10 or 15 minute appointment in the outpatients, but they've driven, a number of hours. They've had to bring all their other kids with them, so it's a huge ask of people to do this, when actually, a conversation in their home about the things that are important to them are really important. So I think this hopefully has brought on telehealth, years in terms of seeing that it can be used. I think one of the important things is sometimes the way we've done things in a crisis isn't always the right way. So we need to go back and look at some of these things like telehealth, for example, and really look at co-designing it better. So I think there was emergency telehealth, and there's lots of other examples of things that came in as emergencies. I think one of the things we need to do is be careful that we haven't designed them without patients and families and other staff members involved in them, because if we want them to be sustainable and to last into the future, then I think that's really important that we co-design them. And I think there's lots of other examples, I think, of things that we've done differently. I mean, even the whole emphasis on shifting care out to the community. Again, there's been an impetus on that because of trying to take pressure off the hospitals, but it was simply the right thing to do. But again, it needs to be done. It needs to be co-designed. You need to think of the principles of quality improvement in terms of it's got to work for patients, it's got to work for staff, Very often, you know, if you get these things working well together, it actually generally has a positive effect on cost. But it needs to be done consciously and carefully so that we do sustain these things.
Mm. Lots of other
questions. Yeah, just didn't quite get back to Warwick, I think, in terms of how do we support clinicians not to just go back to the old way of doing things. What I would say to you as a National Mental Health Service, for whatever that's worth, that you should just do it. Don't go back to the old ways of working. In your area of influence, empower your teams. Keep making the decisions you feel you need to make to deliver care. Keep changing things as you see fit. Obviously, there are rule sets. You can't, you know, we know what the rules are in relation to procurement and other things. We can't break rules. But there leaves a massive amount of scope for still to affect change as we see fit in our area of influence. So seize that and ask for forgiveness afterwards. Don't ask for permission. And quote me if you want to on that. And, you know, that's what we've got to do. We've all got to do this. We've all got to hang on to what worked well individually. I don't think centrally we can control that. We've got to, and if the middle management kind of say, no, you can't do that, say, hold on, it was good enough a month ago, it's good enough now, go with us and you'll see the benefit. And we will see the benefit if people continue to lead innovation in their own space. We'll have a massively better health service.
Yeah, we'll just take one or two more before we move on to the next topic. But there's an interesting question here from Sharon Kennelly about over the course of the COVID experience thus far, we've seen many rapid 1 to 2 page guidance documents and algorithms which have been developed by subject matter experts versus the substantial PPPG type documents that we normally direct practice by. And I suppose just wondering what do you think about that?
I think a lot about it. I really welcome the question because, I mean, my own division was responsible for guidance on PPPG development, and it is a cumbersome approach. It builds on the National Clinical Excellence Committee approach, and I think the tendency is that it leads to tomes being developed with everything that you could ever want in it, but hard to find it because it's too comprehensive, it's too good, and it's like coming back to some of what we said at the kind of throughout this pandemic, the perfect must not defeat the good. The good is good enough, mostly. Perfect is largely a nice idea, but you spend so much time getting there that you lose a lot of people along the way. So yes, we had a meeting of the National PPPG Steering Group at 11 o'clock today, so it's a very timely question. And we considered there from the National Cancer Control Programme a paper on agile guidance development based on our experience of the pandemic. And we're going to adopt that and free things up and try and see like 1 to 2 page pieces of guidance being developed in the space of a month rather than the space of a year, and a 40-page or 100-page document in that period of time. So, yeah, I mean, there are ways of making it much more agile, and we're going to pursue them.
Great. We'll just do one more before we move on. Gillian Berry is saying that it's great to hear the acknowledgement that each member knows their area. Has COVID brought change to working in silos? So many really powerful innovations have been created within the organisation. However, there's no scale. So
these are the best questions, aren't they?
Yeah.
They're so good. They're very hard to answer. I mean, that's a really important question. Like, so we've innovated, we've changed, we've flattened hierarchies. Have we broken down silos? I would say kind of at national level there's been a massive intermingling, and, you know, yes, we have. Actually, out in the system have kind of community service groups come together. That'll vary locally, I would say, and I would say we've still got work to do on that one. What do you think, John?
I think silos are pretty resistant. Look, I think there will have been examples of where silos and collaborative working and where it maybe hadn't happened before has happened. I think again, as time goes on and the kind of the aim is not just how to manage the surge and the immediate danger, but how do we kind of continue to run the health service? That's where it becomes more difficult, and I think siloed thinking will again kind of come into play, and that's where it's critical, to be able to reach out and across silos and to recognise that. Where budgets are, defending resources, that's often what causes silos to occur. I do think, you have to constantly, I think, try to work against silos, and I think see that patient outcomes are dependent on the outcome of systems working together. Patients often don't see the silos, and they certainly don't want to experience them. But I really do think, it'll take a lot of work to keep on breaking those silos down and recognizing kind of that things are need to work together. I think again, this is the more complex part of getting on and at speed redesigning kind of the way the health service works, to cope with not only meeting the demand, but meeting the demand in the face of COVID.
And just the final comment there, thanks for that, John, is from Julie Bellew, and she's really agreeing with what you were saying about the value of co-design and how it would be really great to have some support from QI with respect to this area. So we can come back to that a little bit later when we talk about how we as a QI team would like to be able to support people. So maybe we might move on to the next area, which really is just to give people online a little bit of insight into what the National Quality Improvement Team have been doing since COVID has hit our shores. So perhaps, Philip, you might like to start on that.
We've been lazing around, really, haven't we? We've been putting our feet up and waiting to see out the pandemic. No, we've completely refigured what we've done. Like everybody, I'm not looking for any credit for this at all. It's the only thing we could do, which was try and apply our skills to the priorities of the moment, and that largely was putting our team into creating and enabling the development of a contact management program, which involved the testing and tracing of mainly the contact tracing, really, of people who had tested positive for coronavirus, and that's a fairly elaborate and completely new way of doing it that we've never had existed in Ireland before. And there's an awful lot of complex work around training completely non-health service people to do contact tracing. It was a very big ask for them. So a lot of training and support, a lot of design of the IT around it that we were very involved in. We've kept some of the QI work going as well. I mean, as John's already alluded to, and we come in on this in relation to seeing through the people who are on diplomas. We wanted to make sure that they completed their educational experience. We intend to complete the safety collaboratives that we started on pressure ulcers and falls. We've been working with safety, and we've been doing a lot of work on open disclosure, which is relevant during pandemics and any other time, and assisted decision making. And some of our other work around patient participation has continued as well. So we've been kind of trying to chip away at our kind of core work, but with most of the team being entirely directed towards contact management program.
And we did actually do a lot of work on data as well, Philip. And Naomi, if you'd like to move the slide set on there, we have been contributing to a number of different data reports, and we could share some of those graphs with you. But maybe in the meantime, John, if you wanted to add anything to that.
Yeah, I suppose where a lot of my work is in the providing of teaching and training, and I suppose we've had to adapt in that. And again, there's many people who've participated in the Quality Improvement Leadership Program, which was formerly called the Diploma. So we've changed the name, and the important thing really has been the adaptation. And I think, again, we didn't want this to stop. And I think it was very important that we didn't see quality improvement teaching and training as something that you did only in peacetime, that it was something that was really valuable to learn about, in time of crisis and to be able to apply it. So we've had to move the program online. We have completed 2 of our programs, and our third program this year, the Diploma 18, will finish on Friday. So we've managed to get teams through. It's been a complete revision and a complete change of how we teach, and I think it's also meant lots of experiments. So we've been trying new things. One of the things beforehand, we used to bring people in, obviously, and have 2 days together in the classroom. You cannot just replicate that on online or on Zoom. So we have to kind of try and change the way we do things. So we have a much shorter day, but we're trying to engage people with video, trying to get them looking at various resources, exploring them in the time in between sessions. Trying to kind of get people more, I suppose, in one sense, to engage and become curious to all the fantastic material that is out there, and to kind of explore the community of QI globally. And in one sense, I think we'll have a better course actually for it at the end of it all. I think we'll have people kind of who I think are able to kind of adapt to the problems of now. And I think it was interesting, some of the diploma candidates were deployed elsewhere during the height of the crisis, and we had people kind of who were usually working in community dentistry who were working in testing centers, but they were applying their QI skills in terms of how to manage a process and how to make the testing process more smooth, how to make it more person-centered. So you could see that these skills that they were applying to their normal work were just as relevant in the new problems that they were being asked to deal with.
Thanks, John.
Yeah, and to come in there, hopefully my sound hasn't been entirely clear apparently for people, and I apologise for that. I thought it was good earlier on, but I put in an extra device here, maybe that will enhance the sound quality. Just to say, as Roshan kind of teed me up there, there's an awful lot of data around the pandemic, and it was presented in lots of different ways, and we're very data rich. A lot of really good work by the HPSC particularly. I just want to show you some of the things that we did in the QI team to Gráinne Cosgrove led this and did a wonderful job, where I'll give you an example of a couple of the graphs that we've done, and these are fairly up to date. And not entirely, as you can see, but they're reasonably up to date. That's by week. And what we tried to show was the importance of looking at data in an intelligent way, even during a crisis. So everything we've been saying about data generally has really leapt forward during the pandemic, when it could have fallen by the wayside, but we jumped into the breach and decided to use statistical process control charts and run charts to show the strength of showing data in intelligent ways that prevent people overreacting to, for example, daily variations in new cases. There was massive fluctuation in that graph there on a daily basis. One day there'd be 300 cases, next day there'd be 80. We say we were in a cart when we had 300 cases and we were laughing when we had 80, and then the day after. So nothing had changed in the course of the pandemic. It was to do with the testing and the numbers of tests coming through in a day. So we showed data like this, and we developed it for the operational hub, for the CEO, and it was very widespread. We developed a 2-pager. So it was a 2-page document, and we continue to do it. We'll be doing another one tonight. We're doing weekly at this stage. And this shows the numbers of new cases by week. And you can see it was very, very high, and it came down. Then moving on to the next slide, we can see, again, numbers of COVID. I can't just see that there. COVID-19. Related deaths, it's deaths. And it shows again that was an awful lot higher in June, a very sad period, but it has risen a bit and has come back down again since the 14th of September. But again, showing the value of looking at this over time. And this is the number of people in hospital since the 1st of August. It was way higher before. I mean, it was up to, I think did we have 800 people in hospital? I think we did. But it is, you can see it's clearly rising. So that's why people are getting a bit spooked now. This idea that the virus has become benign, well, that's why we need data to show the virus hasn't changed really at all. There's just a lag time between rising cases and rising hospitalizations. The numbers in ICU, by the way, are stable today, and the numbers in hospital rose over the weekend. Then this finally, penultimately, this is the number of people in ICU, and it shows that it has been, it's stable in the last couple of days, but that shows that all the parameters are creeping back up, not up to anything like the peak before. And this is the advantage of a statistical process control chart. It shows that from a statistical basis, Dublin and Cork are statistically significant outliers. Cork on the low side, so they'd be very proud down there in the Rebel County, and Dublin on the wrong side of the graph, which is why we are in special measures at the moment, if you like. So yeah, we've used this data consistently throughout the pandemic. We have a whole series of new admirers for data for improvement rather than data for judgment and point-in-time data. So yeah, I think we very much have kind of used our kind of skill sets around data to really kind of bed them as throughout this pandemic. And then in terms of what is quality improvement, I think we've seen this in action. Unceasing efforts of everyone to make the changes to lead to better patient outcomes. That's just been better experience. That's just been what's characterized this pandemic, I would say.
And maybe just to interject there, Philip, so you've talked a little bit about what the QI team have been involved in and our experiences over the last couple of months. But I suppose for everyone online, what people are really interested in is like how can we use those learnings to move forward into the next phase of COVID and beyond that, and how can we make changes around it. So we did talk about using the framework for improving quality, for trying to capture those learnings and ideas around the 6 drivers of the framework. Would you like to elaborate? And I'm conscious of time. We still have 115 people online, which is fantastic. Thanks a million. So we might do a speed through on some of the key things on this that we are take-home messages in terms of. Yeah, very big. The framework still holds, if you like. We found it was still useful. All these drivers are still important. I've already talked about leadership and communication, particularly. Working on the common purpose, really important. I've shown there how measurement has been central to. I mean, you can model all you like, but the measurement of day-to-day data and its trend is the most reliable model because it's actual data. It's not a projection. It's not a guesswork. Well, guess is maybe too harsh a word, but it's certainly hard data and it is guided. I've used that data at INO just last week to take stock and say, where are we going in relation to, all right, restarting services, great, but where are we going in relation to existing services? Attention needed at some stage to limit complex surgery that is elective if ICU particularly becomes overstretched. So, that data will guide those decisions and we'll continue to use it. We've talked already a little bit about governance, I think. We've sought to continue to engage patients in everything that we do. I think staff engagement is what I've been talking about, collective leadership, absolutely central. And I think people have been using improving methods in lots of different ways. John, you'd have more examples of that, I think, than I would directly.
Yeah, I think the key point is that the framework, I think, still stands for now and in the time of crisis again, and the time of needing to redesign things quickly. All of these things are so important, and I think, there are some elements of crisis that you just need to get on and do things quickly, and maybe the level of engagement you can have with everybody isn't what you could have if there was a bit more space. But I think we need to be careful that we don't put everything into that box. And I think there's a lot of redesign, and I'm going to take something like, again, telehealth. We really need to work with patients and families about, what are the things in telehealth that make it good? What should be happening? What are the things that we can do to make that experience better? Using improvement methods, again, with things like telehealth, anything new, we have to learn from it. And I think, one of the key ideas in improvement methods is the idea of small tests of change. So even what can we learn from doing one telehealth consultation, debriefing it with our friends, our colleagues afterwards, creating that opportunity to learn from these new things that we're doing. And the adaptation that's requires massive amount of small changes. And it's just to create that culture, there it is in the center of testing, of trying out things, and I think just to, I would really say just to be careful not to neglect, I think, staff and patients and families where in the interest of expediency, sometimes we can do that. I think, I think we if we don't engage people, then I think we will end up not designing good systems, I think, and things that come back to cause problems later on. So the framework is so relevant, to now as much as ever.
Thanks a million for that. We did have a section in next where we wanted to facilitate some more discussion, but I suppose we don't have a huge amount of time. But if everyone could just reflect, I suppose, just thus far on the content that we've given, and maybe think about taking one thing on how they could facilitate improvement in their workplace going forward. Populate the chat box at this time. We'll pick some key themes out of that. But we might move on with the next piece of content and come back to that. So please do populate anything into the chat box. And also if there's something that you want more on, for example, co-design, we could certainly provide a QI talk time at a later date on that. So we've talked a little bit about the QI team's experience, and I suppose, albeit that our resources reduced in terms of our ability to support people with QI, but we're still trying to maintain as much as possible in terms of supports online and other things. So Philip, perhaps you might like to start to tell us a little bit about how we can continue to support quality improvement.
Yeah, we certainly intend to do so. We'll be developing more online both training modules and also materials. And you've highlighted there, I think, something that you, Roshan, were very involved in developing, which is a really lovely resource, I think, and really lays out tools that we teach, tools that we use, tools that are kind of very self-explanatory in the toolkit, I think, that you can apply to that very task that we discussed earlier on in the webinar, which is what can we do to not go back to the old ways of working? Well, let's just use the tools that we have at our disposal, and let's just keep improving things. Let's just keep changing things as we see fit. Let's not ask for permission. Let's just keep doing what we know best because we know our own business. So I think we'll continue to develop online materials, and we have joined recently, as the slide just reminds us, the Q community, and that's something that anybody who's been engaging with us and who's kind of some basis background in QI can engage with and join. They can join the community. It's a cross-national network: England, Wales, Scotland, Northern Ireland, and the Republic. And I've joined, and we're building our membership in the Republic. And it's a great place to share ideas and to crack problems. You can join a group that's working on the deteriorating patient one day, or on preventing pressure ulcers another day. And it's a very wide network with a lot of bright people in it. And when the more Irish people join, the brighter the network will get. Proportionally, shall we say? So. That's the community, and that's an offering that we have now for everybody to join. To join if it's your thing. I think it's definitely something that's worth. If you give a bit of time to it, you get a lot back out of it.
Fantastic. Thanks a million for that, Philip. John, did you want to elaborate any more on any others of your work, for example, the RCPI course, or? and is the other training that's being developed?
Yeah, just to reiterate there, Q is a great resource, I think, and I think one of the key things is that the community, obviously, which it reaches across the UK, they have exactly the same problems and challenges that we do. So, being able to see the ideas and solutions, I think, is great. And I think, there's a lot to take from it. They're also trying to tackle a lot of the problems, that I was just talking about earlier in terms of education. How do we teach QI online? How do you teach, leadership for quality improvement online? And coming up with ideas for that. And so it's been a great resource. Just to mention one project that I've been involved with, and I hope we'll get an output from it later in the year, is and it was a nice collaboration again across silos, or what are traditional silos between colleagues in HR and in values and action, and with our colleagues in UCD as well, which was a project collecting examples of what we were talking about earlier, the best of ourselves, where people, did, create great outcomes by working together. Like Philip said, maybe not always asking for permission, by deferring to their own expertise. And we think there's a lot to learn from those stories. Because, and it is focused on the positive stories, and we know that there was also, challenges and difficulties as well. But it's learning from all of the positive things that happened, and trying to understand, what was it that made that happen? Was it leadership? Was it a sense of collective purpose? Was it a sense that you were in being able to make your own expert decisions? And we want to kind of compile a storybook really of examples of where stuff went really well, and it's to be able to kind of reach into that as an example of our best selves. And hopefully we're going to present that, back for people to see. I think it'll be a really valuable resource for people working in quality improvement and in leadership to be able to pick out these examples. And there was fantastic examples from around the country of, there was a great example from Cork, from CUH, where people were using lean training to figure out how best to use the limited PPE supply they had at the beginning. And it wasn't just about restricting PPE use. It was about getting people to use the right PPE for the right circumstance. So, that staff weren't been overly burdened by having to use the wrong PPE in certain circumstances. But it also meant that they were making sure that the PPE supply was there. And that was just taking, kind of QI training that had gone before and adapting it to this new situation. So there's loads of great examples. I think Philip alluded earlier to the prison services, where they took, really great QI coaching on board to deliver what has been a kind of recognized as a world-class approach to managing COVID within our prisons. So we want to capture all these stories and remind people of really of the excellent work that's happened and that will be needed in the months ahead.
Thanks a million, John. And just Naomi has put in some links into the chat box to some of the documents we related to, but just one other web page that I think hopefully you can see there that I'm sharing that we've created is one on COVID-19 QI learning, and you'll see we actually done a report ourselves within the team about what we did and how we learned from that. But also, I think if you go into this particular link here, QI resources to support learning, it gives both national and international links there in terms of the IHI and ISQA and Health Improvement Hub Scotland. It also gives some tools, two lovely tools, the Collaborate tool, which is a framework for capturing learning from COVID, which seems to be used a lot, and the collective sense-making tool. So if it's something you're looking for in terms of evaluation of an improvement effort, and they're very quick and easy to use. So and also we have some other nice articles there, some of which John was involved in, highlighted at the end there. So just to draw your attention to that. And the other websites are in the chat box. So thank you so much for joining us. And there doesn't seem to be any more comments in the chat box, but people are just saying brilliant resources, and thanks for that. And I suppose just we'd be really interested if people, there was a lot of content here, and we could probably hold a webinar on, but one of the things that came up today. So if people wanted to email me directly, they certainly can, to highlight anything that they wanted to maybe include in a future webinar. So Philip and John, have you any further comments that you wanted to make before we finish?
Look, just to say, I think it's been the message throughout here is that, you know, QI teaching and training is as relevant now as ever. You know, that the current situation will demand continuous changing, and that doesn't have to be, you know, the application to massive problems. It'll be trying to make small changes the whole time. I think working where you can, certainly with your colleagues and with families, to design the system that is able to manage, you know, the world that is in front of us now with COVID, and we have to do that. And I think, you know, one of the key things in that is we have to keep on learning. And I suppose my one challenge to people is what mechanism do you have for learning every day, you know, on the changes you have to make? You know, is it a huddle? Is it an after action review? Is it some way of just purposefully reflecting on, are we learning from the things, or, you know, are we just kind of making the same mistakes or falling into the same errors again? I think that's the great thing that QI has to offer. It speeds up the learning.
Thanks, John.
Yeah, to add to that, John, thanks. I think that'll be something, building on what I would like to say as well, is that, you know, a good idea isn't good enough because we don't know if it works. If we know our ideas, so we do need to test them. So that's where QI comes in. But it doesn't have to be a laborious process. It can be done rapid tests of change, see if something works, and then let's get on and implement it. Ask for forgiveness afterwards. Quote us as saying that's the way we got to work in the future. You know best. Stay in touch with us. We'll continue to develop different offerings for the system and partnerships with the system. So, and we'll continue to run these webinars as well, as you can see there. So I really appreciate so many people taking the time to share some time with us and for us to see you as well. So thank you all very much.
Thank you.
Thank you all, and thanks very much to Philip and John for their active participation as always. And just to highlight, we are doing our quarterly webinars starting from today. And thank you for sticking with us with a few little technical issues, but not too bad. So the next one is CTE tackling an increasing problem during COVID-19. So our speakers are from the Mater and Rotunda and from both Ireland. So we're looking forward to that one. So all of these really are COVID related, and we're trying to integrate QI into all of them in terms of the learnings and what people are bringing forward from that. So thanks a million, everyone, for joining, and we look forward to you tuning in again next time. Thank you.